Chapter 14 is muscles, skeletons, and joints, and it is a fairly large chapter, so we're going to get right into it. Starting around page 580 in your text, where we will begin explaining the role or function of the musculoskeletal system. You can see here 206 bones and more than 600 muscles. There is no way we're going to be going through all of those during this class, but you will learn all of those in anatomy and physiology at one point or another. Maybe not every one of the 600 muscles, but you'll learn at least the major ones. And I would say you would pick up all 206 bones, which is a little bit easier because you learn them in sections of the body. And then, of course, the different joints, which we've got a little bit of experience with already from a couple of the different chapters talking about arthritis. Function is pretty straightforward. It's the framework in order to provide structure for our body. So it's the support system as well as protection. So like the brain and soft organs like the brain, the spleen, the liver, the kidneys, the lungs, the heart, they're all protected inside of a bony case. So bones are for a number of things, including, again, the support structure and then the protection, as well as movement. Obviously, we wouldn't be able to move if we didn't have the muscles connecting to bones. So muscles and skeletal are nicely designed and formed together to complement one another. So if we look at the bone structure, this is where we see figure 14-1 on page 580. If you're on page 580, you can kind of follow along with that picture of that bone there. Periosteum is the outside or the outermost area of the bone, and you can sort of see towards the bottom of that image the outer layer of the bone, and then they sort of peel away layers as you move down from that. After the periosteum, you have the compact bone, which is the really dense layer underneath the periosteum. Then the cancellous, which is what's often known as the spongy bone because it looks spongy. It's got all of those holes in it, so it looks much like a sponge looks. And then the endosteum is the inner part of the bone. And here you can see, because this is a long bone, we have long bones in our body, such as the bones in our arms and our legs, and then we have non-long bones, which would be like the bones that are in our head or fingers, ribs, things like that. But the long bones, mainly your arm and leg bones, or your extremities. So you can see the endosteum, which is the inner part of the bone, and actually it's just the membranous lining. So it's very much like the periosteum, how it lines the compact bone. The endosteum lines the inner part of the bone, including making for a space of that hollow cavity, which you can see inside of that, and that's called the medullary cavity. Breaking the bone into sort of different sections, you've got the diaphysis, which is the shaft of the long bone. So not every bone will have diaphysis and physis, but the long bones do. On each end, you see the epiphysis, and then the diaphysis is the shaft. Within the bone itself, you have two different types of bone marrow. The red marrow, which is a blood-like material, and then yellow material is a fatty type of material. And here we see this image that we were just looking at in our text. Some skeletal bones being listed here, and this is fairly long list that we'll get into. It starts on page 581 and then jumps over to 584, starting with the maxilla and the mandible of the skull. So that's your upper jawbone and lower jawbone, and those actually articulate. We're not going to do a lot of bone structure of the head at this point, but know, there's lots of different bones within the skull. They're all sort of fused together at birth. They are not. They actually have some space in between them, and then as the child grows, then that will fuse together. Once you're adult or mature, then all those bones have fused. And instead of just being one individual bone, calling it the skull, which oftentimes we do, if we need to be more specific, we'll talk about the individual bones of the skull, but we're not going to do that in this section here. The vertebral column, you can see a picture of that on page 581, and it shows you a lateral view as well as an anterior view. And then it breaks the vertebral column down into the vertebrae, which would be the plural form, or vertebra, the singular form, and then the different types of vertebrae. So groups of cervical, thoracic, and lumbar vertebrae. And so you can see the cervical are the top 7. It's that first set forming the neck. So the whole reason you can bend and articulate your neck is because you've got 7 vertebrae there that are allowing you to do that, that all articulate with each other. And then moving down, once you get past C7, you've got 12 more vertebrae, which are your thoracic vertebrae. You see those again on page 581. Thoracic vertebrae would basically be like your upper and mid back area. And then you get down to your lumbar vertebrae, which is basically from your butt up to the sort of like that middle, that little arch of your back right above. Like if you were to stretch back, that sort of arch back there, the bottom half of that would be your lumbar vertebrae. And then we have the sacrum and the coccyx. The sacrum don't look like vertebrae, it just kind of looks like a big snake head almost made out of bone. It's actually 5 vertebrae that are fused together. And you can sort of see a vertebral structure to them. However, they don't look like a normal vertebrae does. And then the coccyx is itself, it's the very tip of the sacrum. And it's actually 4 tiny little vertebrae fused together. But again, nothing sort of form or function like the normal cervical, thoracic, or lumbar vertebrae. The other thing to note about the sacrum and the coccyx is they are not innervated. So the rest of the cervical spine, you will see spinal cord innervation, but coming off of the sacrum and the coccyx, you don't have that level of innervation. The lamina, if you're just looking at the individual vertebrae itself, kind of where the vertebrae comes together in the back, those 2 sections are called the lamina. Again, part of that vertebral arch of the vertebrae. Not super important for you guys to know at this point. However, the lamina is in your list there on page 584. Just kind of, if you're wondering what that looks like, if you just do a quick Google search for lamina or vertebral lamina, you'll see the section of the vertebrae that it belongs to. Continuing on with skeletal bones, clavicle. So these are your 2 collarbones. Oftentimes these are what gets broken in pediatrics. So we get lots of pediatric collarbone fractures, as well as higher adolescents and teenagers as they start playing sports, and especially contact sports. Collarbone injuries are pretty easy to have happen. The scapula is the term for the shoulder blade. So if you reach back here, the shoulder blade is what you're feeling on the posterior section of your shoulder. Upper extremities, arm and hands. So here you've got a humerus on each side. So the upper arm would be your humerus. And that's oftentimes where they say, okay, well, if you hit your funny bone, it actually doesn't have anything to do with the humerus. And the humerus is spelled different than as in funny or joke humerus. It is different, but it is called the humerus. And then in each arm, you have an ulna and a radius. In the wrist, you have several carpal bones, and then you have metacarpals, and then your phalanges are your fingers. Move down to the lower extremities. Looking at our legs, we have our femurs, which would be analogous to the humerus in our legs. So you've got the 2 femurs, the really long bones, really big bones of the leg. And you've got the patella, which is just a tiny little kneecap. In each lower leg, you have a tibia and fibula. We'll see those pictures like on page 594, sort of the fill in the blank section, which you can get the answers from pages 582 and 583. You can see the tibia and the fibulas. The fibulas being the smallest of those bones in the leg, the tibia being the biggest. In the upper arm, radius being the bigger bone, and the ulna being the lower bone. In the leg, then you also have ankle bones similar to our wrist bones in the upper extremities, but in the upper extremities, those are called carpals. In the lower extremities, they're called tarsals. So you still have tarsals, metatarsals, which are analogous to the carpals and metacarpals of the upper extremities. And then the phalanges, again, phalanges for toes or fingers. Now it says 28 here, and you might be thinking, but I don't have 28 toes, last time I checked, and that's correct, you don't. But if you look at the sort of a breakdown of what the toes and even the fingers look like, every time you've got that knuckle in your finger or your toes, each one of these little bends, that's a different phalange. And then the entire finger itself, we would give a name to, like thumb, pinky, middle finger. And we would typically just number them as far as medical is concerned. But that's why you've got so many phalanges, is because each time you've got a joint there, you have an articulation, that is an individual different phalange. Those are the main skeletal bones that are covered in this chapter that we'll be using as far as medical terminology. And again, as a very brief, sort of the biggest bones in all the sections of the body, not going into some very specific or high level detail, which you would find in your like bio classes, especially anatomy and physiology. So then we look at joints, and we can see the definition of joints listed here, that it holds bones together and makes movement possible. So that's, again, just looking at anywhere you've got a bendable part of your body, that's made possible by a joint. So you got bones that are coming together and meeting up, yet they're not stiff, like bone to bone. You've got some type of articulation that allows them to move back and forth. Within all of these joints, then you have all kinds of connective tissue, including cartilage, tendons, and ligaments. And we'll be speaking about those as well. Those are the items that actually are holding the bones to themselves. The bones are not fused to each other in any way. In most cases, they don't even touch each other. When we have diseases and some of the cartilages and connective tissues break down and the bones actually start touching each other, it becomes very painful, causes inflammation, and causes problems with our patients. That's where we'll see them come in and need to have things like hip replacements and knee replacements, shoulders, things like that. So this articular cartilage, a smooth layer of firm fibrous tissue covering the contacting surface of the joints. Again, so you've got these bones that are trying to articulate with each other, but you've got this covering that acts as sort of a layer so that they can move smoothly with each other. So inside of these joints, you have all kinds of different features, such as the meniscus inside of the knee, or intervertebral discs inside of the skeletal vertebrae, in between each vertebrae. So intervertebral, you've got these cartilage discs in order to sort of help that spine sort of float and articulate so we can bend, but also helps for compaction. So if you ever like jump off of a building or something like that, or over a fence, if you're playing sports and you jump up, you know, when you're landing, you're getting a lot of impact. And if we didn't have those discs there, we would just have bone smashing on bone, including our nerves, which are in that system, and that would cause a major problem. Continuing on with joint terms, and you can find these on page 586, and they actually show you the knee joint there in figure 14.4 on that page. So showing you pictures of what some of these items look like. Synovia, which typically we just refer to as synovial fluid. Oftentimes we wouldn't use the term synovia. And so synovial fluid is typically what we're talking about. And that's basically just like the suspension fluid that's inside of your joints in order to help sort of cause a fluid type of suspension and lubrication for those areas. The bursa, you can see a picture of that on the lateral view of the knee image on 586, sort of underneath the kneecap there, right at the top of the tibia, where it connects with the femur. You can see the bursa sac. And that's, like, again, just another fluid-filled sac that allows for easier movement. The ligament and tendon, these are important to keep separated. Lots and lots of medical procedures with ligaments and tendons, especially with orthopedics and sports medicine. So a ligament and a tendon, they basically are doing the same thing. They're like a band of connective tissue, but a ligament connects bone to bone, and tendon connects bone to muscle. And so that's the big difference between those two things that you want to remember. Again, ligament is bone to bone, tendon is bone to muscle. Aponeurosis, which we'll see that term being used a few times on lists. Aponeurosis is like kind of like a tendon, and so connecting muscle to bone, but instead of just like a thin ribbon type of tendon, it's actually like a big sheet tendon. One area to think about, well, where would you have an aponeurosis as opposed to a tendon, would be your pectoral muscles. And so your pectoral muscles, basically then as they come over and attach to the bone, you basically have just this big sheath of connective tissue that does that connection. And so because that's such a broad muscle, it uses this broad tendon, if you will, called the aponeurosis in order to do that. And so it's just like a fibrous connective tissue sheet rather than just like a ribbon type of shape of tendon in order to attach muscle to bone. And here we see that knee joint that's on page 586, including several different aspects of it. On the lateral view, you can see the patella really well. And then the tendons, okay, so then again, you've got the tendon connecting muscle of your upper leg to your patella or to a bone. Same thing down here. You've got ligaments inside of your muscle, inside of that joint connecting bone to bone. Okay, so that's helping your femur and your fibula connect. And again, that's using the terminology ligament. You may have heard for sports injuries, things like the ACL or the MCL, so like the anterior cruciate ligament or the medial cruciate ligament, lateral cruciate ligament, just depending on which part of the leg was injured. People, you know, if they're playing basketball or football and they're making really sharp cuts, they're likely to blow out one of those ligaments. And so here we can kind of see which ligaments they're talking about as far as actually needing to be replaced at that point. A couple other things that we're seeing from the frontal view. We can see this meniscus. So that's kind of like that disc almost. It's almost like a vertebral disc, but it's in the knee. So it's like a fluid-filled suspension that's in there. And then you've got your articular cartilage, which is the cartilage that's on the epiphysis of both of these bones, which then are contacting the meniscus. And all of that together is allowing for a nice, smooth articulation between those two bones. From the frontal view, we can see the medial cruciate ligament, and then we can see the lateral cruciate ligament. And then there's also one on the inside here on the front of the knee, which is not shown on this, which would be your anterior cruciate ligament. Looking at muscle tissues themselves, if you look at page 587, we've got the three different types of muscle tissue. So skeletal muscles are the striated tissue. So these would be, again, like your arm, your biceps, triceps, hamstrings, your quadriceps, things like that. So anything that's really, moving your body and going to be picking up or taking on an extra force, those are your striated skeletal muscles. So they're very strong and they're able to produce just amazing different levels of acuity. So you've got very, very precise control, but then you also have huge control as well to lift very, very heavy things when necessary. These are known as voluntary muscles. So striated or skeletal and voluntary all are analogous to each other. And voluntary because we control those muscles. And then smooth muscles, which are unstriated. And if you look at the picture between A and B on 587, you can see the difference between those two cell types just under the microscope. Clear difference there between the two. They're unstriated when we're talking about smooth muscle. Now, these muscles are what we would see surrounding the airways, like the bronchi of the airways, which are responsible for them contracting or dilating, such as in asthma. We also see them in the digestive tract. We've talked about peristalsis being the movement of that muscle in order to move foodstuff through your digestive system. I think that was back in chapter 11. So that's where you would see this smooth muscle, and these are involuntary muscles. These muscles are activated without you thinking about it and without you telling them what to do. So they just happen. When we put food into our mouth, our brain is starting to warm up our digestive muscles so that in 15, 20 minutes, when that food starts to enter the small intestine, it's ready to start moving it through and grinding it up. We just don't even have to think about it. It just sort of happens. Same thing with your airways. If you have asthma and you're out running and you're getting short of breath, or maybe you get into something you're allergic to and all of a sudden your airways start to constrict, you have no control over that. You're not thinking, oh yeah, I'm going to constrict my airways, or I'm just going to relax and, think about doing something different, and that's going to make my muscles dilate. That's simply not the case. Now, getting rid of whatever was causing the irritation or stopping the exercise and relaxing and doing those things will help possibly because you're getting rid of the stimulus that's causing it. But that's just it. You're getting rid of that stimulus. You're not necessarily doing something to actively dilate those muscles. And that's where medication comes into play. Again, involuntary. And then the last one there on 587 at the bottom in image C is your cardiac muscle, which is forming most of the wall of the heart. Most of the heart itself is cardiac muscle. And again, here, this is involuntary. It's completely handled on its own. Of course, we looked at the SA node in the heart, which is what's controlling the heartbeat as far as an electrical stimulus when we were learning about the heart in the cardio system. However, these muscles and its drive or its stimulus to beat has nothing to do with what our brain is doing. Again, we can, relax. We can sort of take some deep breaths and focus on something else. And we can get ourselves to relax so that our heart rate will slow down. But when we start running, our heart goes up because we need more oxygen to get to our tissues. When we stop doing that, the demand for oxygen goes down, and therefore the heart slows down. That's nothing that we have control of in our brain itself. It's just a physiological response to the needs of the body. This next is types of body movement. And so we could see the image here. This is on page 591, and the chart for it is on page 590. And so here we see these different terms. They're pretty easy to remember. Extension is going away from the body, and flexion is to the body. So if I think about, okay, my arm, if I flex it, that's to the body. Extended's going away from the body. Your head's kind of a difficult one. What's extension and what's flexion? Well, this is flexing because it's coming to the body. This is extending because it's going away from the body. Pronate and supinate are pretty easy as it refers to the palms. So supinate would be a palms up. Pronation would be a palms down. And we talk about proning patients in the hospital sometimes, where we'll actually put them on their stomach in order to treat them instead of laying them supine on their back. So supine and prone are two different terms which we typically use for body positioning. But if we're going to use it in terms of how do we want a patient to turn, or how are we going to position a patient's body in terms of moving them for a surgical procedure, then we would be talking about, okay, we want to pronate the arm or we want to supinate it. And so if you're working like in surgical technology and you're assisting a surgeon with a procedure, then knowing pronation and supination is going to be important, because you may have to move them in order to put them in a proper position for the surgery. Abduction and adduction. Well, I guess the easiest way to remember this is abduct. If someone gets abducted, they're taken away. So if you abduct your arm or your leg, you're moving it away from your body. And if you adduct something, you're adding it to, or you're bringing it back. So adducting would be bringing it back towards your center line or towards your body. So abduction away, adduction towards. Eversion and inversion is pretty similar. This image is kind of difficult to look at. It kind of looks like, okay, these are the patient's 2 feet, but they're not. Notice that the big toe or the great toe is both on the same side on both of these feet. And so eversion, this is just the same foot going away from the body is eversion, and going into the body is inversion. And then of course with rotation, just depending on what direction are you rotating, this rotating your head either direction, that's not an abduction or an adduction or anything else. You could, I guess, say, okay, I'm abducting my head by turning it away from my body, but it's not really going away from your body, it's just rotating. I would not use those terms regarding someone's head. Otherwise, someone is going to think, oh, you abducted someone's head, meaning you're taking someone's head away from their body. And that's not what we're doing. Combining forms of the musculoskeletal system. And we see this chart starting on 592 and then over onto 593. We see terms like carp for the carpal. So like of the wrist, we talked about those carpal bones and the metacarpal. So carpo would be referring to that. Clavic for clavicle, again, your collarbones. Claviculo, again, just a combining form or root word in order to talk about things with the clavicles. Costo is dealing with your ribs. So anytime you hear the term cost or costo, that is your ribs. Cranium or skull. Femur or femoro is the long bone of your leg, of course, in the upper leg, femur. Fibulo, dealing with your fibula. Humero, humerus. Ili and ischia, talking about like the ilium for your pubis or your pelvic bone. So we will see that when we look at the pelvic girdle a little bit closer. And I think it might show that on, yeah, if you go back to page 582, you can see the pelvic bone. And you can see the ilium, which is the largest portion, sort of this is like your waist, if you will, your love handles. And then the ischium, which is basically like the butt bones, if you will. And then the pubis is the part that joins in front at the center line. Mandibulo and maxillo, of course, dealing with the mandible, and the maxilla, lumbo for lumbar or like lumbar vertebrae. Continuing on, patello, of course, kneecap there, the patella. Pelv and pelvo for the pelvic bone, again, phalange, so again, fingers and toes. Pube, going back towards the pelvic girdle, and the pubic bone, which again is the part that's joining the pelvis together, center, anterior center. Rachio, spondylo, and vertebro, you can see those there as well regarding to vertebrae, the spine or the vertebral column, so basically just your backbone, that whole column. Radio for the radius, okay, ulno, the last line on the other column here for the ulna, so radius and ulna, both are those two long bones of the distal arm. Sacro, sacrum, scapula, again, the scapula, your shoulder blade, sternum, breastbone. Note that all of the ribs are joining to the breastbone, at least once you're fully developed. You do have cartilage that is helping to join those together. It's not like bone on bone. It's not just, formed bone on bone, but there is an articulation there. Tibia, tarso, again, so lower leg, instead of carpal, we have tarsal for the bones of the lower leg, such as the ankle bones, basically. Combining forms of joints, the aponeuro, so we looked at the aponeurosis earlier. Remember, that's that large sheet. So it's basically like a tendon connecting muscle to bone, but it's a large sheet instead of just a strap or a band. We've seen this arthur and arthro quite a bit when we talked about joints and inflammation previously. So such as arthritis, that's pretty common. Bursa, bursa sac, chondro, cartilage, disc, disco, again, so like vertebral discs in your back, meniscus, the synovial fluid, tendons, tendineae, all of those, again, demonstrating their combining forms. Musculoskeletal specifically, ankylo, kinesio. Kinesio, you're going to see a lot in that kinesiology or kinesthetics is basically just like movement. And so you'll see that sort of used in a lot of different ways because it's a very broad term, just meaning movement. Ankylo, meaning like a stiffening or a bending and a stiffening. So you might have a body position that it doesn't have its full range of movement anymore. It's a lot stiffer now, but it's bent. And so that would be the ankle. Kypho for like kyphoscoliosis. And we'll see some of these shown a little bit in more detail, like scoliosis here, the last one on the list on the right, and lordosis, the last one on the list on the left. Otherwise, we see quite a bit of familiar terms like the osteo, of course, meaning the bone, and the myo. We saw that previously with the muscle. Some prefixes, you can see those on page 599. Inter, of course, we know that means inside. Supra, above or out of, and then sim and syn, meaning together or joining. So like a symbiotic or symbiosis. Suffixes, I turn the page over to page 600 and we can see this list of suffixes. So the asthenia, so such as myasthenia, which would be muscle weakness. So asthenia is just a suffix meaning weakness. Clasia, classis, and clast, meaning breakage, often referred to with speaking about bones. Schisis, the one on the bottom there, we talked about that a little bit before, a fissure or a split. So a schisis in the cranium or the skull of an infant or of a newborn would often be referred to as a schisis because it is a split of those bones or a fissure of those bones, which will then join together. And you can see those other two terms there, the desis and the physis for the surgical fixation and growth. Disease and disorder terms built from word parts. So these are going to be fairly straightforward. We've seen quite a bit of these before, like the osis, a condition of, and then the ankylo. We just saw that one with our combining forms, meaning a stiffening or bending. So a condition of stiffening and bending. Of course, we've seen arthritis and this itis suffix over and over just about every single week, meaning inflammation of what? Of the joint, of the bursa, and you can just continue to add that, of the meniscus, of the maxilla, of the osteum, so the bone and the joint, OA, osteoarthritis, so the bone and joint inflammation. And then a couple of the other terms which we've seen before, like malacia, meaning a softening, and chondro, meaning cartilage, so softening of the cartilage. That cranioschisis we just mentioned, they've got that fissure, and then cranio, meaning cranium. So again, lots of terms here that we've seen before. Fibromyalgia, that algia part of it, meaning the pain. Then looking at the fibro part, fibrous tissues, connective tissue, and pain. So you've got a fibromyalgia. Sometimes it's hard to pinpoint where that pain is actually coming from, because it's that connective tissue. So if it's in this area, it's like, okay, I've got this elbow pain. Okay, well, where is it at? It's sometimes hard to pinpoint that. Maybe it's an inflammation that's causing it, or maybe there's actually a tear or something else. Typically, if it's a true fibromyalgia, which oftentimes is spoken as simply as a disease state or a condition, you know, you'll hear someone say, I've got fibromyalgia. It'll mean that they have a recurring connective tissue pain in usually one isolated area of the body, but sometimes it can be multiple joints as well. So here we see a couple different types of arthritis in regards to the knee joint. And so you could see slide A is the normal joint, and then you've got B, osteoarthritis, and C, rheumatoid arthritis. Difference, the osteoarthritis is basically just something that would take place as a result of using this joint over and over, and sometimes in actually abusing that joint. So football players, track and field, outdoor enthusiasts, if you're running on treadmills or on hard streets a lot, you can just totally destroy your knees as a result of that. And that would be an example of like an osteoarthritis, as opposed to rheumatoid arthritis, which is going to be the result of an autoimmune type of system response, to where it actually is destroying those cartilages and ligaments and connective tissue, tendons inside of your knee due to that autoimmune response, as opposed to just being physically abusive to your joints. So look at some of these disease and disorder terms continuing. So we kind of did the first half, and now this rest of this chart is on page 603. And it's kind of cool. This is a neat page because it shows us a bunch of x-rays of some of these bones as well. So you could see the A, B, and the C, the different types of arthritis from our previous image. And then you can see the x-rays of these images here as well. And what's neat, like especially if you look at page 602, that top image, image A, you can really see the epiphysis of the long bones there. You can clearly see the differentiation of the tops of those bones between the diaphysis and the epiphysis. Continuing on with the list, again, really something that we've seen a lot of, the itis, lots of times on this page too, in relation to then whatever the word roots are. So osteo, again, bone, and chondro, cartilage, bone and that fibrous tissue, softening, malacia, softening of the osteum, so it's bone softening, bone and muscle softening, osteopenia, decrease in bone density or bone mass, sarcoma or the oma, again, back with cancer, the schisis, the rachis, remember the schisis was that fissure, so we saw that, and the rachis meaning vertebral column, so a fissure of your vertebrae, rachis, rhabdomyolysis up here at the top of the right-hand corner. So typically we see this when you have skeletal muscle being damaged to some extent. So if you have a major trauma, if you have torn muscles or major surgeries where you've got to cut through a ton of really large skeletal muscle, those muscles will actually leach out enzymes that can be toxic to the rest of the body. And so rhabdomyolysis is something that oftentimes we'll see in the patients in critical care. Some disease and disorder terms not built from word parts, the ankylosing spondylitis. Remember that ankylo, we saw that term previously, just seeing sort of that stiffening or that bending of that area. And so here we see that term being used. bunion. Just about everyone has seen someone with a bunion, especially as the weather gets nicer and feet start coming out and they're no longer in shoes, but in sandals. It'll oftentimes look like page 608, sort of like the big toe is just like going out and then it comes back in. It can actually be very painful. It can cause a lot of mobility issues. Surgical procedure to fix that is common, but extremely painful. Requires quite a bit of recovery as well. Carpal tunnel syndrome, we're familiar with that as far as sort of people who are typing all of the time now, which we're seeing quite a bit of, especially more and more now with all of the online work. With the carpal tunnel syndrome, you can see the flexor retinaculum. That's that huge tendon right there that's on the palm of your hand. So it comes right across through here. Underneath that, you have the median nerve. The median nerve comes up and then spreads out to the rest of your fingers. Well, when this median nerve is constantly being damaged from us typing and keyboards and constantly pushing on this portion of our, whatever, keyboards is typically what we're doing, but on the desks when we're using our mice and things like that, then it's causing sort of that pressure on that median nerve constantly, and it can lead to carpal tunnel syndrome, and then they have to come in and help relieve the pressure on that median nerve in order to allow sort of that hand and that nerve to heal. And then the next one on that list was the Colles fracture, which I'm showing here. And there's another image of it here in your text, but you can see on this x-ray, you've got both, actually two fractures here on this patient. So where the arrow is, and I'm just going to kind of trace along here, you can see sort of that line on the radius bone right at the end of it where it starts to join with the carpals. And so that area there is a typical, what we would call a Colles fracture. And this one is just like a sort of like a hairline fracture. It's actually bigger than a hairline fracture, but this one is not displaced. This one, however, over on the patient's right is displaced a little bit. And it's actually more than just sort of like a fracture, but you can see there's fractures here and here, here. There's one vertically here. There's fractures there. So this one is pretty severe. It's got a lot more breakage in it than the one on the left does. This is your typical, you fall, and so what do? You put your hands out. If you're roller skating, when you fall down on your wrists like this, or you fall backwards a lot of times on your wrists. So this is one of those types of sort of skate park injuries that we see all of the time, or ice skating. Really any type of activity where you're going to be falling down on your wrists on a regular basis. That's where you're likely to get these Colles fractures. Back to the list of fracture being further down the line, again, just that FX as an abbreviation, and we can see the CTS is the carpal tunnel. We'll see this at the end of the unit as well. The exostosis, just extra growth on the bone. So this would be your typical bone spur. So the medical terminology for that would be exostosis. Gout, the picture on page 609, the top one, A, is a good picture of gout. And that's just a buildup of uric acid in the joints. And it can be painful. And sometimes you actually need to have it drained. A lot of times you hear about it in the knees and in the knee joint, and then having the gout drained from your knee. So it'll cause your knee to be swollen. You won't be able to see or palpate the kneecap or the patella like you normally can. So it'll kind of look like it's just fluid overload and you've got a lot of edema in your knee. It doesn't go on to the rest of the lower extremity. So it would maybe not bother your ankle. So you could rule out that it's like edema from renal failure or heart failure as opposed to gout because of where the swelling is locally and it's isolated. But oftentimes they'll go in with a needle and they can actually pull gout out and drain that out, then allowing the normal motion to take place again. Looking at that on 609, you can there see B is the osteoarthritis or the swelling of the bones in the joints. And you can really see how those joints are swollen of the fingers. And then the rheumatoid arthritis, you can see, has a completely different presentation in that, you get this sort of disfiguring of the placement of the phalanges as a result of the disease that's taking place. Herniated disc Staying on 609, I'm looking down at that image at the bottom. So if the graphic, the one on the left, you can see the herniated disc, and it's showing it actually sort of like pushing into it's actually pushing into the spinal column. And so you can see right here, it's pushing in. That pushing in is going to pinch that nerve. And then this is the sort of top down view of it. And you can see the disc here, this part's the disc. Because it's herniated, it's being squished this way, and it's pinching your spine, your spinal nerves against the rest of the vertebral bone. That's what causes so much pain, because it's actually pinching your nerves when it does this. And so that causes some major pain issue, usually wherever that nerve then is innervating. So a lot of times it's in your lower back, and it innervates your lower extremities. And so you might have leg pain or leg numbness because of a slipped disc or a bulging disc or a herniated disc. All of those terms are commonly used. The X-ray on page 609 at the bottom, that image B, you can see between the cervical vertebrae there, between 6 and 7 where those arrows are, you can actually see the spinal cord being pushed in by that disc. And again, so that's going to cause major issues wherever those nerves are being pinched by that disc. And that's then why you have to go in and have a decompression done or a discectomy, where they cut part of that disc out. Nice thing about that is typically, as soon as they take that out, you have instant relief. Sometimes that nerve can sort of be like shocked, and it might take a day or two, but most people find immediate relief from that as soon as it happens. I know this is kind of redundant, and I've said this almost every single chapter, but this takes us all the way back to chapter 1, where we looked at those two different types of categories. Type 1 being built from word parts, and type 2 being not built from word parts. I keep going back there because it's important, because that determines how we're going to figure out how to learn these words, whether we can break it down by the word part or whether we have to memorize them somehow, learning from the names like an eponym, or from actual English or modern language, or from acronyms. So here on page 10, looking at the rest of this chart, Lyme disease, on page 10, at 610, it actually shows you a picture of a tick that is carrying Lyme disease, and then shows you a lesion on the patient's skin that has Lyme disease. And so of course in Montana, we've got a lot of wooded and mountainous areas. We have lots of ticks, both on sometimes us and our critters. So Lyme disease is something that we typically hear about quite a bit. Usually we'll see a little bit of a Lyme disease spike in the summer with fishermen going out, and then people going out hiking, and then in the fall, before it gets too cold, with hunters out scouting and whatnot before the season starts, especially if they take animals with them. Like if their dogs are out with them, they'll be going through the brush and picking up ticks. And so Lyme disease, sometimes we'll see a spike in that coming into the hospital. Muscular dystrophy, MD, listed there. Again, that's a nice acronym talking about disease that is a degeneration of the muscle, so the dystrophy and then muscular. So again, each one of those terms is going to help you, but altogether not built from word parts like we're used to seeing. Myasthenia gravis is a neurological disease where we have degenerative neurons, so the transmission of the neurons does not flow through the system, and it ends up causing a little bit of a paralysis from the top down, called myasthenia gravis. It's temporary. It usually comes and goes. Sometimes it can be severe enough to put someone on life support because it causes them not to be able to breathe. Osteoporosis, of course, bone, and then the porosis aspect. I think everyone's heard of osteoporosis at some point, with a loss of bone density. Plantar fasciitis, again, is really common with teens and young adults that are doing lots of running, older adults that are running on the streets and sidewalks. And some people just have it even when they aren't necessarily active or athletic, but they just have that inflammation of the plantar fascia, which causes them major problems. Rheumatoid arthritis, we looked at a picture of that yesterday. Again, just autoimmune, causing joint inflammation. Spinal stenosis, this is a narrowing of the spinal column. You can see this on page 611 up at the top right-hand side. Shows a thickened ligament causing a stenosis in this case, as well as some largening of the facets or faucets, which are holding the vertebrae together within the spinal column. Some of those have grown large, and so it narrows the column that the spine is supposed to go through, And as it narrows, it provides pressure on the spinal cord. And of course, that can cause neurological issues throughout the body. This is kind of an interesting list of terms from other names, things like kyphosis, also known as like a hunchback or a humpback. And so this would be where you kind of see grandma hunched over a little bit. The shoulders are kind of hunched over and they walk like that. That would be a kyphosis. Scoliosis. So this picture here is looking at it from the side view in. But if we were looking at the back of the patient's head, this is the back of their head and this is their spine coming down, we could see they actually have like a lateral curvature of the spine at some point called a scoliosis, which we'll see here in just a little bit. A lordosis, again, if we're looking laterally at this patient, the lordosis would be where the lumbar vertebrae kind of kick out. I did that the wrong direction, where it actually kicks in. And as it kicks in, it causes the top thoracic vertebrae to kind of kick out. And so you end up with this like puffed up chest type of appearance. And they call it lordosis because it looks like you're walking around with a big chest, like, look at me, I'm lording over you. And so that's sort of a result of that lumbar vertebrae issue. And we talked about the bunion, also called hallux valgus. No one ever calls it that. Everyone calls it a bunion. So some funny kind of words in these lists, but perhaps if you were in a podiatrist's office, you maybe would see that. And then the big one down here is the herniated disc, which you can see all kinds of different names for it. Common names that you're going to see. Here's that spinal stenosis picture that we already looked at. We already looked at the herniated disc. We jumped forward and looked at that. So then skipping over to some surgical terms, nothing new here other than the word roots. So we have lots of these raphes, the centesis, ectomies, otomies, plasties. It's just a matter of what are we working on. So, you know, the meniscus, the maxillary bone, the lamina, the disc, the cranium, costo, remember the cost is the rib itself, condo for cartilage, and so on and so forth. We've looked at the arthurs before, so nothing really new there. Carpectomy, remember the carp, that's carpal for like the wrist, so like carpal tunnel. And then this list is just continued, and again, nothing new here, just the word roots, you know, so whether it's bone, osteo, phalanges, patella, for the kneecap, rachis, we talked about that with the spinal column, vertebral column, vertebro, tendons, so tarsals, synovial fluid. Same word root, our new word roots, and different procedures in discussing that. On page 614, there are some good images here showing you some types of arthroplasty, which is joint repair. And so they show two really common types. One is a total hip, and then one is a total knee. And you can see there of the hip, how they do that. You can see the combination between, okay, the bad hip and then the good hip due to the osteoarthritis. Rarely are you going to see just like one perfect good hip and then the person has one bad hip. Usually you're going to see two bad hips. One might be worse than the other. And a lot of times they have to have both hips replaced. It's just a matter of spacing it out so you can have time to recover from the one hip before you have the second hip done. But here you can see what they do. They basically cut the entire top end of the femur off where it fits into the acetabulum of the pelvic girdle. And in doing that, then they drill it out and they put in this implant, which has a ball joint head on it that then fits into the acetabulum and allows that hip to then be good again. Kind of similar with the knee. You can see that knee with the osteoarthritis and all kinds of problems there where it's no longer freely articulating at that knee joint until they, again, cut those sections out and then replace them with these metal implants that are going to allow for a good articulation of that joint moving forward. Some diagnostic terms, imaging terms, so like an arthrography, so again, joint, an exam of the joint. Endoscopy, just scoping out the joint. Again, here we've learned about this Arthur term before, so looking at that joint is really nothing new. EMG or an electromyogram, again, they're looking at that muscle tissue sort of electronically, not exactly like an ECG where we were talking about looking at the heart tissue electronically, but this would be slightly different. Page 616 shows a percutaneous vertebroplasty. This is a kind of a cool picture where they show a fractured vertebrae. It's actually a compression fracture. So when you jump or when you're in a car accident, lots of times football players get this if they hit head on they'll have that fractured or compressed spinal column, and that'll cause one of the vertebrae to get compressed and then fracture inside of it. They can actually take in and implant then this almost glue or cement paste that is going to fill in all of that fractured area and thicken and harden it back up. And you can see what kind of that looks like there. Some complementary terms. So moving over to page 622 is what we're looking at now. All kinds of complementary terms built from word parts here. So we're going to see lots of things that we had seen in the past, stuff like bradykinesia. So brady meaning less than or decreased amount of, and kinesia meaning like muscle movement. Other words like carpal and clavicular, costochondral, again, just referring to that body part that the word root is demonstrating. Dystrophy would be like a destruction of, dyskinesia, an abnormal amount of muscle movement or something's wrong with that muscle movement. And then the right side of the list, again, lots of those words we learned at the beginning of yesterday's session in regards to what type of bone it's actually talking about. So in some cases, it's two bones like the iliofemoral and then the like ischiofibular. We're working on two different types of bones there. So if we're talking about the two bones, especially where they join together, like ischiopubic, that's how we're going to be using those terms. Continuing on, big list here, talking about lumbar, osti, pelv, subcostal, costal, mandibular, maxillary. But again, nothing new. This is stuff that we've already gone over. Continuing on, again, this is a really big list. Not built from word parts. Some of these can be new to us, but like I just mentioned, podiatrist, as in the study of the foot, also known as a chiropodist, but again, no one really ever calls it a chiropodist. However, you do hear of a chiropractor and chiropractic a lot. So we do see that. Crepitus is a term when you've got two bones that are rubbing together. So if you were to take your knuckles and marry them together like that, so they're actually lined up and they smoothly go in there, and then you push together. So I'm pushing in on them and I'm pushing in and then I'm pushing up until it kind of clicks like that. And I don't know if you guys can appreciate that through the mic, but kind of that little clicking noise. Imagine if you've got a broken rib and the ribs are, normally the one rib looks like this, but if it's a broken rib and the rib is now like this, fractured, and you breathe, and every time you expand your chest, these two bones go click, 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 and they rub against each other. Like that can be really painful. That's why it causes a lot of pain when people have broken ribs and it really slows them down. But that sort of like clicking of the bones rubbing against each other or flaking past each other is called crepitus. Anytime you have broken bones or just joints that are rubbing with too little cartilage, then that's when you will hear crepitus in that joint or in that area of the body. Clavicles can do the same thing with a pretty severe clavicular break. Ortho, we mentioned ortho quite a bit. So orthopedics, orthopod, orthotics, again, study, and the people who do study in the medicine of orthopedics, so bone. So we see a lot of hips and knees. This would be a typical orthopedic patient, physician. And then the abbreviations for this chapter, which we've already seen quite a few. Remember the C is for cervical, T for thoracic, L for lumbar, vertebrae, and then FX like fracture, RA for rheumatoid arthritis, MD in this case for muscular dystrophy, MG for myasthenia gravis. Oftentimes what will happen is you'll find, again, these terms, it's like, wow, like there's multiple abbreviations being used throughout multiple different sections. For example, MD, right? I mean, we call doctors MDs all of the time because they're a doctorate of medicine, yet here it's being used as something else. And RA, as respiratory therapists, we write RA all the time on everything, meaning the patient's on room air and that they're not on a nasal cannula or don't have any supplemental oxygen, but they're just breathing the normal room air.